Good morning from Miami Beach. This is Dr. John Bennett, Neurosurgical TV. We're honored with the presence of Juha Niemi, who's going to present the neurosurgery grand rounds for China. And we certainly welcome the Chinese neurosurgical community, and we appreciate Dr. Liao. Hello, Dr. Liao. I'd like the community to see your face. Are you there?
Hello, everyone. Yeah, I'm here. Hello, everyone.
Okay.
Can you hear me?
Yes, we can. Thank you very much. Thank you very much.
Yeah, you're welcome.
Okay, everyone knows Juha. Okay, it's all yours, Juha.
Okay, dear colleagues, dear John, dear Dr. Liao, who is translating in Chinese. So I take my lecture here.
Okay.
Can you see it?
Yes.
Okay, today we have two honored guests, Professor Ali Christ and Professor Emad Abud from Arkansas Neuroscience Institute, Little Rock. They are world famous, and Ali has been here in our webinar earlier and has been also operating on here in Shaolin Congress. I think 3 times he has been operating at the Henan Provincial People's Hospital in a live course. So we know him well. He's one of the great microneurosurgeons, and Emad Abud, originally from Syria, is taking care of the cadaveric laboratory at the Arkansas Neuroscience Institute. So we will see 2 presentations here, and I give a small introduction in the here. So one most important thing is always that we should give credit to those who have been teaching us, and actually we are standing on shoulders of many of our teachers. But the main thing is that we continue there where they have finished. So I was studying my medical studies in Zurich. In Zurich, Switzerland, there was a great school of neuroanatomy. Long tradition of anatomical dissection, and one of the most famous anatomists was Professor Konstantin von Monakov, originally from Russia, but he moved already as a child to Switzerland and then became professor of neurology, neuropathology in Zurich, and there is even me in the Brain Research Institute could see the von Monakov laboratory there. So long tradition. He was founded the Swiss school. Also the Professor Meyer was his student, and many others followed him. My teacher in anatomy was Professor Chayan Tenduri. I remember extremely well in Zurich, 1968, when he was giving a lecture. He was shouting without microphone his lectures, and he was shouting, "Medical study is a lifelong study, and anatomy even more." And this remains for all the times so true. So in anatomical department, there were also Professor Stefan Kubik, originally from Hungary, and Professor Kurt Tyler. They taught me hard working, and I learned really to work hard in Switzerland. This was the first time to very hard working. And in the Anatomical Institute, so the cadaveric dissections were extremely highly credited and well organized, and this one I have not seen so well after that times. So the Anatomical Institute was extremely important, and the cadaveric dissection for the medical students, very important. So after that, during my medical studies, I joined Brain Research Institute, headed by Professor Konrad Ackert, and I learned to use the microscope. Here you see OPMI-1, and I learned rat and cat brain anatomy. Besides that, I saw also the old von Monachov laboratory slides of the human brain. So learn anatomy. This is extremely important. If you learn anatomy well, then you will do good microneurosurgery. This is extremely important, and the following lectures are telling about that. So if you have the possibility to go to cadaveric laboratory, even in the presence of many human cases, so go. There are excellent laboratories, cadaveric laboratories in St. Louis, Little Rock, Istanbul, Berlin, and so on, in many places in the world, but not everywhere. This picture is coming from Wisconsin, by courtesy of Dr. Emil Avsi, one of the cooperators in the great cadaveric laboratory, North Carolina. So cadaveric laboratory working might be difficult. It may depend on the culture, society, religion. Not all neurosurgeons have possibility for cadaveric work, but if you spend some time, serious time in cadaveric laboratory, then you will learn a lot for your surgeries. If you can draw, you should draw. If you can record during your operations, do it and study these videos, records of your own operations. This is very important. And nowadays you have extremely good books, preparations, videos on neuroanatomy. You can take a look on them. You can buy good books, good videos, but you have to work on them. Otherwise, they are of no use for your learning. And as mentioned in the beginning by Professor Jayan Tenderi, the learning curve is whole life. Here, this is a classical photo from Chicago, 1988. And here once more the sentence. Medical study is a lifelong study, anatomy even more. So we are never ready. We have to have open mind, learn all the time. And remember that our great teacher, Professor Yasakil, is still studying at the age of 95. So life is too short to learn all the anatomy. So I give the word after this slide. Thinking back on my career, what would I have done differently? Many things in my neurosurgical life I would have done differently, but I think I should have spent 2 serious years in cadaveric laboratory to learn better. Of course, if you have a cadaveric laboratory in your own hospital, then you can drop in easily and train. And this is, for example, at the Arkansas Neuroscience Institute, well planned. In Helsinki, it was so that the anatomy, forensic anatomy was 7-8 kilometers away from our hospital, and it was not possible to dissect cadaver heads in our hospital. So this makes a big threshold for training. So you should have organized that you have a cadaveric dissection in the same house so that it is easy to go there to learn. So I give now the word to Professor Ali Christ and Professor Emad Aboud to tell about the organization in Little Rock, USA. Thank you very much. Should be okay. I ask him.
Okay, we're connecting, huh? While we're waiting, you, how is the COVID over there in China? How was the COVID situation?
Cases yesterday in all China.
Oh, really? Okay.
12 cases.
Oh, wow, that's amazing. It's amazing. And it's really, really tight quarantine, right?
Yeah. Dr. Liao, you have the tapes? Can you run them?
Oh,
Hi. You said I will play the video of Professor Ali.
Yeah, run it now.
Yeah, I have the video. Should I?
Yeah,
okay.
Go ahead.
Go ahead.
Sorry, wait a second.
Okay. Oh, Vinco's here.
Vinco is here?
Yes.
Oh, welcome, Vinco. Great honor.
Oh, good. Excellent.
Can you manage, Dr. Liao? Can you run them from my computer? Wait.
Okay, we'll get it together. There we go. Okay, yeah, there we go. The audio, now the audio.
Can you see my screen now?
Yes, we can see it. We need to work on the audio now.
Can you hear
Vinco, don't screen share. We were going over this yesterday, the screen sharing. Okay.
Begin, yeah. Dr. Liao, begin again.
Yeah.
Try it again, yeah.
With voice.
Can you hear the voice?
No, cannot hear. No.
Okay.
When you screen share, there's an option to pick to share the sound. Okay. When you start the screen share, you're going to start the screen share over. Okay. You have to. Are you screen sharing with Zoom, right?
Experience with your conference.
There we go. There we go.
Congress.
Is it? Now you can hear the voice.
Yeah. Yes.
Okay, I will start again.
Okay.
Good morning, everyone. Good morning to you in Shaolin. And good morning from here in Little Rock in the United States from the Arkansas Neuroscience Institute. I want to first thank you for giving me the chance to share the experience with your conference and Congress. And I am sorry that the unfortunate times did not allow me to be with you in Shaolin, and I'm hoping maybe next year we will share the same conference room together. I had the opportunity to be working with a lot of people over the years, and I want to give special thanks to Professor Ernestine Yuha, my friend and one of my teachers, who has really left an impact anywhere he goes. And we all can feel that he has become the gate of China to the world and the world to China. Thank you, Yuha. And I'm looking forward to see you in the near future. This is any of my lectures and any of my work is tribute to my teachers, starting with Dr. Al-Mefti, Professor De Oliveira, Professor Dolling, and you have Professor Ernestine. And we all belong to the same school of thought, which is the Yazergil school of thought. And the essence of this school is to do high-level microsurgery and provide the best for patients. And the only way you can achieve this is really by going to the laboratory to study the anatomy in details and do as much dissection so you can master the operation. And this is the theme of my talk that I'm giving to do today. So to be able to achieve mastery and excellence, we have to recognize that this all starts by mastering the basics. What are the basics? Anatomy. You have to know the anatomy inside out, whether you're operating on a glioma or a meningioma or a chordoma or another meningioma in that region, or operating on aneurysms. You have to know the anatomy inside out. And I'll give examples how the knowledge of the anatomy has helped us advance our knowledge of the pathology as well. So our institute has a really strong spirit of anatomy and being a referral center for problems which cannot be treated somewhere else. And the reason we were able to achieve one step forward is because we spend more time in the lab than other colleagues, to where we're always trying to advance the field. This is our center, which was a vision of Professor Yazergil, which has the Yazergil Research and Education Center. This is our auditorium where we do a lot of our courses, and it's connected to our operating room with 3D capabilities. I hope one day you will visit with us. And it also has a state-of-the-art laboratory named after Professor Al-Mefti. And this is our lab. This is one of my Chinese fellows, Kai Li. And Kai Li is becoming a master in the cavernous sinus. I'm sure he will be one of the best surgeons in the future. And we also have a conference room named after Professor de Oliveira, also one of my mentors, which has a 3D capabilities as well. So the setup, this is next to my operating room and next to my office. And this is why I spend a lot of time in the laboratory, which by knowing the anatomy at its depth, then you can know the pathology and how it behaves, because when you're operating and you see how different nerves and different structures are pushed, then you know how the tumor grew. And if you know how the tumor grows, you know how to remove it safely and better, and more radical resection can be achieved. So the understanding of the anatomy leads to the understanding of the pathology itself. And I'll give examples in this case, because this knowledge will give you a different eye. It's like what Professor Yazergil describes as the brain eye. You're able to see with your brain, which is more of inside than just the sight and the vision. You have more ability to see beyond what you're looking. This is a great example where Michelangelo used to be given a marble, and to produce a sculpture, he can see the angel in the marble, and he carved it until he set it free. This is the way we should do our surgery, and I'll take examples how we learned it over time. A good example is the cavernous sinus. A lot of tumors have been described, and you can see this is a publication where the drawing is wrong. It's not the case. Why? Because they didn't understand the normal anatomy. And this ends up with unfortunate outcomes to patients with a lot of recurrences like this. Even though we operated and cleaned the tumor, it was too late, because if we caught the patient in the beginning, we would have been able to achieve better results. So incomplete work results from incomplete knowledge of the anatomy. And this is a failure, but it's okay if we fail. We shouldn't look at it as the opposite of success. It's part of success. We should build on it. And nowadays we can operate in the cavernous sinus, for example, much safer and more, achieving more and better results for patients and less morbidity, because we have a better and in-depth understanding of the anatomy. So I'll give you my view on the anatomy of tumors of the cavernous sinus, which they arise in this corner and they grow in different ways. And the real cavernous sinus tumor really is a tumor of the tentorium and the cavernous sinus. And I like to call them cavernotentorial meningiomas, not different names which are confusing. So let's look at how the lab helped us by looking at the distribution of the tumor and correlating it with the MRI. For example, in this case, if you look at the picture on the right side in a second, you will see where the tumor is located, while this tumor started in this corner. That's where they always start, under the fourth nerve, medial to the third nerve. They start extending into Meckel's cave in this region, and eventually to the petroclival junction through the dura into the sellar and parasellar region and along the tentorium posteriorly. And that's how these tumors grow. If you know this, and you know that the nerve is on the surface, while the sixth nerve is the only one inside, and how they invade into Meckel's cave, then operating on it becomes easier because we're no more operating on tumor, we operate on nerves. We find where the nerve is normal, clean some tumor, find the other side, and then bridge it in between. And that's how it changed our knowledge. We had more understanding of the pathology, then the surgery became safer, and the ability to remove these tumors became possible. So things are going to look complex, but knowledge makes things simple. And the best example is the cavernous sinus region. So in this case, the surgery is done on the nerves.
Nee, كريه جون يا
The tumor itself.
شان دروك.
And I'm showing
لا
this
ندخل يا very.
and the real life. So we start by coagulating the middle meningeal artery because
كاكو
allow us to mobilize the dura more posteriorly so we can reach more posterior points for the resection. And then we come to the meningioorbital artery, and the way we cut in the lab is taught, and then you come and do it exactly how you can achieve the initial dissection phase for the lateral wall of the cavernous sinus and separating the dura propria from it, and so on. So this will allow us eventually to get to where we can see the anatomy in a nice way and exposing all the elements before we start removing tumors. So we start seeing the nerves in different parts where the nerve is normal. And then we come to the dissection process where we start the dissection usually along the fourth nerve, which is followed until it starts going into the tentorium. Then you stop. You don't follow it if it's filled with tumor. Then you find the other end of it after we open later. And then we come and clean the extradural part. And then when we open the dura, you can see the tumor here and the fourth nerve coming in, the third nerve here. And then the anatomy becomes clear because you know in detail how it's distorted by the tumor. So this is fourth nerve, third nerve. This is V1, V2, V3. Sixth nerve is going to be in this corner. And then we are opening Meckel's cave, removing the tumor from the roof of the fifth nerve. And then we continue with this process, and gradually the tumor is removed and the anatomy is becoming more and more clear. So that as we get later, we find the sixth nerve. There are specific landmarks for the sixth nerve, how I find it. It's beyond the scope of this lecture, but at least to give you a taste of how we clean all these tumors. Then we go down to the petroclival region to expose the basilar artery, and this is the view you get when you finish the surgery. You can see the anatomy very clearly of all the structures, and the tumor is very well cleaned. And this all correlate with the anatomy. You can see how you can see. And the surgery is all done under the brain, avoiding it. Larger tumor, same thing. We will correlate this with the anatomy. And this is a tumor on the right side, which was going along the tentorium. You can see that's why I call it cavernotentorial meningioma. Same steps. If you learn it in the lab, you can apply it in real life, and exposing the middle fossa, cleaning the tumor. This is the fourth nerve, second nerve, V1, V2, V3. We mapped where the carotid is. And then the next thing is to open and try to remove the tumor, which is inside the middle fossa, and that's arising from the tentorium. And you'll see it now once we open, it is hiding under the dura. And if you notice, the surgery is all done under the brain, and that's the advantage of applying what you do in the lab to real life. So once the resection is being done, then you will see here how the third nerve is here and the third nerve is here. We know how it looks from normal to normal, and there's tumor in between. Then you start cutting in a tangential way without disturbing the tumor. And you continue with the resection, and the nerves are kept intact. You can see how I'm cutting tangentially along the nerve. And then by the time we finish the surgery, then you will see that the anatomy becomes more clear. Fourth nerve, this is the third nerve, and all the structures become really clear, and it correlates with what we see in the lab. This picture is similar to this picture, and it correlates with how you see it in the laboratory here. And at the end, we remove this tumor, and you can see how clean it looks. And the patient has good functions.
No.
And this is in the first few days post-op in the hospital still.
No
You can
double
see
vision.
her eye movements. Now, sixth nerve used to be a problem, but then we went to the lab, found exactly how to release the tension on it by removing the petrous apex. Once we did that, we came back, and you can see how we're able to clean below it because we removed the petrous apex. And we applied it then in different patients in order to achieve better results. That's cutting the fifth nerve so you can see it. Again, all this is done in the lab, and then we do it in real life. This is an example. Patient presented with sixth and third nerve palsies. We operated on her, did this technique, and then post-op, you can see the functions of the nerves on all these patients are really good. So the oculomotor nerve, none of the patients in the last 3 to 4 years have developed new permanent deficits. It's important that we should catch these patients before they start having deficits. And we know that the trend in the cavernous sinus is to wait until the patient has damage of the nerves, then you operate on them, because you don't want to blame yourself that you've caused the problem. But nowadays, in our institution, we're able to, I can guarantee that the nerve is not going to be affected. Abducens nerve is the one that's most difficult to dissect, but nowadays we're able to dissect it in a much superior way because we went to the lab, and we have much better outcomes. The problem with the abducens nerve is if it has deficits, they don't recover as good. That's why it's better to catch them before they start having problems. Trochlear nerve is the best to recover because it's really on the surface and compression of it is not too bad. Other examples, we can go through the whole cavernous sinus for exposure to other tumors like this claval chordoma. And the steps are the same. In this case, we have opened the cavernous sinus, but again, we did it in the lab, and the steps repeated the same. You go to the lab, back to the operating room, and so on. So this is what we want to achieve, because the tumor is hiding down here. And then you will see the same picture like the lab, fourth nerve, third nerve, internal carotid of the cavernous sinus, fifth nerve. And then the tumor becomes on the surface, because this is the basilar artery. And the resection of the tumor becomes then an easy part. This is the sixth nerve. You can see it. And that's the third nerve on the other side. So the anatomy of these cases becomes very easy to achieve. Now, we can use the same thing to advance our abilities to treat aneurysms, which, like in this case, this is a 35-year-old female who had a subarachnoid hemorrhage in 2011. She was coiled and recoiled many times and kept recurring. And I was sent this picture by one of my previous fellows from Holland asking what to do. Unfortunately, this aneurysm, I had the same week an aneurysm like this, which using these new approaches through the middle fossa and the cavernous sinus, we were able to clip it without any problems and having to deal with the recurrence of the aneurysms, because basilar aneurysms are known to recur more than other aneurysms. And that's why a lot of them are curable. It's not fair for the patients. So the approach is a modified pterional, which has a more pretemporal route. But the important thing is, by knowing the deep anatomy, we have this exposure, which allow us to get a wide window at the depth of the exposure, so that we can see the aneurysm like this, fully visualized. How? By adding many steps. And if you notice, there is a clip here and a clip here, and still we're able to see the aneurysm fully. And this is the case. You can see the steps of it, and I will advance it. We opened the sylvian fissure and we did the pretemporal approach. And now we are skeletonizing the third nerve, because when you mobilize the third nerve, it will recover fully. And if you don't mobilize it and there's tension on it, then the tension can cause injury. So now this is a very tight space, but we gradually start opening it. We open the petroclival dura, and then we need to visualize inferiorly the basilar trunk. So we take some of the bone of the posterior clinoid, and then we look back to the region of the aneurysm, in this case, a hypoplastic posterior communicating artery. And then you can see by the end, we are able to see very well all the little perforators. And by the time we clip the aneurysm, it is clear from any, you can see everything around it, and there is nothing included. And you can get a perfect result like this, instead of having a problem. So if we don't elevate our understanding in the lab, how to do things better in surgery, we will end up with very bad results in many patients. Instead, we can have a nicer outcomes, because these are curable problems. Aneurysms are curable problems. And if you look at this case, for example, we did not too long ago, look at the approach for this aneurysm. This is the view of the approach. And this is the dura of the temporal lobe, orbit, and frontal lobe. This is the meningioorbital artery, and then we dissect the lateral wall of the cavernous sinus, exposing all the elements in it. And as we do that, then we delineate all the nerves. Then we open the dura, open the sylvian fissure, as described by Professor Yazergil. And now we skeletonize the third nerve. So we are widening the space, and gradually you can see the space becoming more clear. This is posterior communicating artery being cut. And look at the view that you get. It's a majestic view for getting close to the aneurysm. Then we can put a clip on the basilar artery in a perforator-free zone like this. And then we can put another clip on the P1. And then we swing the microscope, and now you can see the aneurysm. And you can put a clip and collapse the aneurysm, and you have a perfect view of the whole anatomy. This can be achieved. It is safe, it is good, it is durable for patients. Otherwise, we'll end up with problems like this, or like this coiled aneurysm, end up with a big stroke in the brainstem, like you see here. It is not fair for these patients. We have to keep our bar very high. Michelangelo said the greater danger for most of us lies not in setting our aim too high and falling short, but setting our aim too low and achieving our goals. We should aspire for better. Another example, ruptured aneurysm. You can see how complex it is. It is not good for endovascular. You can see wide base, but this was able to be clipped because we had a nice exposure. This is the basilar artery, temporary clip, third nerve, this is the basilar artery, and now we can put the clips safely, we can see around it, we can reconstruct it, and so on. By the time we finish, you can see the aneurysm being collapsed. Then I will put a pilot clip, remove the clip, work on the aneurysm, get a perfect result to look at the neck. And then we will put, once we get everything dissected and clean, we will put the perfect clip. In this way, you cured this problem. And we're operating under the brain and away from it, because the approach through the cavernous sinus or part of the cavernous sinus takes you to that region. And by the time we finish, you can check everything, making sure that nothing is included. All the perforators, everything is clean. This can be achieved for more complex aneurysm, much more complex aneurysm, and so on. This is really not fair. And in a very low aneurysm like this, you can go through the whole cavernous sinus, open, like we did for the chordoma. And now you are looking directly at the aneurysm. This is a very low aneurysm. The basilar was below the clivus. You can see the view. The next thing is when you put the clips, it's a very easy process, because with aneurysms, the most important thing is exposure. Once you achieve exposure, then the clipping becomes easy. So I will go show, you see, we have had a large experience now with this approach, 183 more, it's actually close to 190 aneurysms in the basilar area. In ruptured aneurysms, 83% are doing excellent, and for unruptured, it's even 95% with the modified Rankin scale of 0 to 1 and 92% of patients. This is a progress, this is advance. Professor Yazig is very excited about this approach because it takes us one step further in achieving our goals with almost full recovery of the oculomotor nerve. So paraclinoid aneurysms are a great example for how the anatomy understanding will make clipping those aneurysms very easy. Those are different types of aneurysms, but it's all centered around the clinoid process. We have to know the anatomy of the bone, the dura, the artery, the different nerves around it, and then you can do a full exposure to this region. This is an example, medially projecting aneurysm. You can see the surgery is all done extradural nowadays because of our ability to go to the lab and learn how to do this. In this case, we are exposing the middle fossa by mobilizing the dura away from the superior orbital fissure, and then this is V2, V1, and then we remove the clinoid process and expose the carotid in the clinoidal region. Now we get proximal control very quickly. And then this allows us, this is fibrin glue injected to the cavernous sinus. This is a technique that we developed with Professor Anatomy. And then when you open, in this case, you don't have to open except a small window in the dura. So the surgery became all extradural. And then the clipping part becomes the easy part. You can see the aneurysm now. And you don't see much of the brain. Aneurysm surgery should not be brain surgery. Aneurysm surgery is subarachnoid surgery, and it should always be like this. And now you can see this is not a small aneurysm. You can see how it is pushing into the optic nerve here. But this approach, this exposure, made it so easy to clip the aneurysm. At the same time, not to see much of the brain. And a lot of these patients go home within a couple of nights in the hospital, almost like coiling an aneurysm, except you cure this problem. You don't have to put them on any antiplatelets, and you achieve a great result in these patients. You see, the window is so small in these cases. More complex one like this, we needed proximal control. Nowadays, with our ability to expose the cavernous sinus, this is the carotid in the cavernous sinus. We have a clip on it. And then we can come and start planning this is the carotid, cavernous carotid, clinoidal carotid. The opening of the dura is small. And then by the time we get the exposure, this is the optic nerve. The clipping becomes the easy part. This is, again, aneurysm surgery is all exposure. Exposure is anatomy. Anatomy is going to the laboratory. And that's how you achieve these easy goals. So even very complex aneurysms like this, we were able to treat them surgically. This case had other aneurysms. A lot of times now we use a stent for those. But in this case, we were able to clip the aneurysm, collapse it within the cavernous sinus. You can see the aneurysm reconstructed. And this is how it looked. And what we did in this case is we clipped it and occlusion and reconstructed the cavernous carotid like you see it here with 2 clips. So in conclusion, mastery needs that we go to the lab. And that's how we can make the complex becomes simple. This is Professor de Oliveira. God bless his heart and give him strength with this problem that he has. He always spent time in the lab. Professor Yazigi is always in the lab. Professor Anatomy goes always to the lab. Professor El-Mefti is always in the lab. I am next to the lab all the time. We have to have the courage to do new things, but we have to have professional competence. To be able to do that, you have to learn anatomy, to learn technique, to master it in the laboratory. Then we will have no limits to what we can do. but we should always know our limits when we start. I'm going to finish with this picture. This is the eagle, which you can see a raven going above the eagle. But the eagle is smart. The way to get rid of the raven is by going very high and then making the raven having difficulty breathe because the oxygen level goes down. There are a lot of options that are used for treating pathologies in neurosurgery. But microneurosurgery, when it's done at a very high level, is superior to other options. And this is, let's be as smart as the eagle, which is able to get rid of other problems by going at a higher level. Higher level microsurgery is superior to a lot of what's being done. I'm hoping one day you will be with us in the future in our institute. We have a lot of courses that we do in our labs. They're very well attended. There is a lot of young people who want to be good microsurgeons. And I want to thank you for the opportunity, and I hope to see you soon in Shaolin, hopefully next year. Again, thank you very much.
Great, great. Okay, Juha, do you want to take some questions or move on?
Is there any questions in the chat, or someone wants to ask something?
Yes, there's a question. Harshad, do you want to come on camera and ask that question?
Vinko is here.
Oh, okay.
Maybe
Vinko,
Vinko can join and answer the questions here.
yeah, yeah, all good. We'll double team him.
Do.
Okay, Vinko, are you there?
Yeah,
Unmute, Vinko. Are you there? Oh boy. I guess not. We'll get a hold of him. Juha. Harshad Parekh.
Yes, John.
Oh, go ahead, Harshad.
Yes, Professor, excellent presentation as usual. This is third time I'm listening to him. I just wanted to ask the question that when you are putting a temporary clip, how long you can put it safely? Do you use any neuroprotective agents to prevent the vascular ischemia? If so, then what are the agents you use? Thank you.
I studied with all the cases of Dr. Drake and PLS, around close to 1,000 basilar tip aneurysms and the temporary clip, use of temporary clips. So 5 minutes is always safe in basilar tip. Middle cerebral artery is different. So in basilar artery, 5 minutes is always safe. And if you take the clip away, then the total time is 15 minutes. So repeated clipping. This is always safe. If you make, for example, 3 times 5 minutes, it is safe. But if you go above that, then you might have difficulties. So you have 15 minutes time in basilar artery.
Do you use any neuroprotective agents?
I'm not using. I try to do it as fast as possible. In former times, that we were using barbiturates or that kind of things, but it takes a lot of time and to prepare, and so I didn't like it. I try to make it as fast as possible.
Thank you.
Vinko, welcome. Welcome, Vinko. Unmute.
Okay.
Okay, there you go.
Do you hear me?
Yes. Welcome, yeah. Vinko. You want to introduce him?
Welcome, Vinko. Welcome, Vinko. Vinko is one of the greatest neurosurgeons of all the time, so he doesn't need any introduction. We are extremely proud that he's joining us here and commenting us, and I can tell that next week he will give a whole presentation next Friday. But here we are very happy to hear all his comments on this Dr. Ali Christ's lecture. Actually, it was Vinko who made the route to Cavernous sinus. So Vinko, go ahead.
Thank you for the opportunity. First of all, I would like to congratulate to the lecture. It was very clean, very clear, and everyone who was listening and watching must be convinced that this kind of surgery does not go unless you practice in the lab. That's number one. Number two, according to the question, for how long the basilar artery could be closed, I follow the experimental studies of Peter Bentivoglio, who made the experiments on apes when he was in Queen's Square Hospital, and he realized that if you occlude the basilar artery for 3 minutes and you dissect the aneurysm and the surroundings, and then you release the occlusion for 5 minutes, you can repeat this many times. The record of how long the carotid, the basilar artery was occluded in one of my cases was over 40 minutes. 3 minutes on, 5 minutes off, 3 minutes off, on, and so on. So the brain does tolerate shorter, let's say, deprivation of the circulation here, but does need to relax. So alternating, and I was very happy with this. And I have another comment, which is maybe not so important anymore, but we have to keep in mind that cavernous sinus in basilar tip or basilar trunk aneurysms is functioning. So it is full of blood. We have to be sure how we'll deal with this. In nowadays, when we have a fibrin glue, it's much easier. But in my days, I used some kind of coagulants, you know, and you could block it too much, then you block also the carotid artery. So now with fibrin glue, it is much easier and much safer, I would say. And it does show also that endovascular treatment in some cases may not be the best because the perforators might be occluded. With open surgery, it is possible to visualize the perforators and to save them. That's my comment.
Thank you.
Thank you, Vinko.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Okay, does anybody else in the panel have a question or comment they'd like to make to either Juha or Vinko?
Yes, John, can you hear me?
Yes, go ahead.
Yeah. Professor Juha, good evening. This is Dr. Vernon from Mumbai, JJ Hospital. And I'd like to congratulate you for your talk, and also John for doing a wonderful job. Keep sending us the emails. And Professor Yu has also done workshops in our hospital. He has done a cadaveric workshop around 7 years back. And my question is to Professor Yu. I think, Professor, for basilar tops, you prefer the subtemporal approach, because I've read some papers where you say the subtemporal approach for basilar top is much better. So could you highlight that, please, for us, why you feel it is better rather than the conventional terional?
One of my teacher was late Professor Charlie Drake, and he was using the subtemporal route. And he had a very wise sentence that you should use the approach which you know well. Don't
Correct.
change all the time. Take a new one. If you know one route, use it and learn it well. So I learned this subtemporal approach, and I know the tricks to use it well. But of course, this transcavernous approach shown by Ali Christ here is in wide use nowadays, and I think Vinko is doing the same way. So I think every approach has its advantages and disadvantages. It depends on the surgeon and experience a lot. So I think one of the drawbacks of the subtemporal approach is that you have compressed the temporal lobe. The thing you have to manage well is the lumbar drain, and you have a slack brain, so you don't make a temporal lobe contusion, but then you are coming from the side of the aneurysm, and you never are doing any skull base work on the subtemporal approach. So never need that because you are coming from the side. So this is the advantage, and it is a very fast approach and simple approach. But of course, you might do better with transcavernous approach if you can do it well. So this is my thinking. I have done my cases, maybe 300 basilar tip aneurysms I have done by subtemporal route. If the aneurysm is extremely high above the posterior clinoid, then you should use a transsylvian approach, because otherwise you compress the temporal lobe too much. Or if the associated aneurysms could be by the same approach. This has been my practice earlier.
Thank you. Thank you.
Thank you for the
About
question.
the occlusion times, may I say, about the occlusion times of the basilar artery, it depends, of course, a lot on the posterior communicating arteries. How are the posterior communicating arteries? So if they are extremely strong, then you have a lot of time, or actually you don't are occluding the circulation if you put the basilar artery temporary clip, because if the posterior communicating arteries are extremely strong, so it is difficult to assess the right time in these patients. So you should look under circular filicity PCAMs, how they are. But what Vinko said is reasonable. So it was also Dr. Drake's practice. So he put the temporary clip, then took it away, put it back, and this is, you give blood again to the brain. This is very good way. Is it okay with my answer?
Okay, I believe so. Any more comments?
Okay.
Comments or questions? Danu, do you have a question? Looks like you're in a car.
Hello.
Oh, okay.
I'm in Zoom now.
Okay. Let's see here.
It's been an honor, John.
Oh, go ahead. Hey, Zo, how you doing? Are you in Paris?
No, I'm in Indonesia.
Okay. Oh, okay.
Jakarta.
Welcome.
Yeah, I've been actually wondering about how to clip the ophthalmic aneurysm from extradural by doing the clinoidectomy extradurally. But Professor Ali Chris already mentioned it and explained it very well and very inspiring. I've never seen anything like that before in my life. Unforgettable. Thank you, Professor Juha also, and Professor Pioling. Thank you very much.
Thank you for the
I
question.
think next meeting I will ask questions. Right now I'm driving. Also, I cannot miss this.
Multitasker.
Thank you, Professor. Okay, thank you.
So would you like to comment, Vinko, on the extra or intradural approach to the ophthalmic aneurysm? So you are doing always extradural.
Are you there, Binko?
I will show the next Friday the video about the carotid, but the carotid ophthalmic.
Yeah.
And
Next day, 1.5 hours.
pardon?
1.5 hours you have time. Up
Okay.
to you.
Now,
Everybody's waiting for you.
now.
No, next week, next week.
Okay,
Next
my
week.
God. Just a second. Let me see then. If I can find it.
December 11th,
Just a
the
second.
same time, 8 o'clock.
You're not going to present a long video, are you, Binko? You're going to do that next week.
Just a second. Just a second.
As you can see, we have tight production here.
I don't find it now.
Take your time.
I don't find it now.
Okay, next week. Next week we take.
I will present it next.
Yeah.
Okay, you'll have lots of time
next
next week. You'll have lots of time. Okay.